Pravinji, is the screen visible?
Yes, it is visible.
Okay, thank you, sir. Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. Today's topic is case-based approach to management of MDR-TB, and the speaker is Dr. S. Kumar. Dr. S. Kumar has completed Diploma in TB and Respiratory Diseases and MD in General Medicine from MMC. He has been associated with GHTM Chennai since 1999 and recently retired as RMO and Nodal Officer at Nodal DRTB Center at GHTM. He is recognized as Master Trainer for NACO and TANSACS as well as PMDT services. He is a co-author for many papers on HIV and TB, and his field of interest includes care and support for HIV and TB patients. We also welcome Dr. Roshan from Stanley Medical College and GHTM. Dr. Kumar sir, we request you to start the session. Dr. Kumar sir.
Am I audible now?
Yeah. Yes, sir.
First of all, I thank the iTech and Sweta for this excellent opportunity given to me today to be amongst our colleagues. And in this grim situation, again, I'm back. We had NDLS on March for the management of MDR-TB. Now we are back with recent guidelines and case-based approach. But also, thank you for your kind words of introduction. I think we proceed to the session. Can we have the first slide? Roshan, I think you are. Thank you. So, before what we have planned like this, first we have a lecture, followed by Roshan is going to present case HIV, TB, MDR-TB patient, which we'll be discussing. And before that, we will be having a small lecture on the recent changes in the guidelines. So before going to the MDR, actually the epidemiology is very important. So what is the TB burden in the world, the global versus India? This is the TB burden. If you take it in the 2019, 10 million cases, out of which 1/4 are from India. Okay, and then the incidence of MDR also 0.5 million globally, and we have around 27%. That is 1,24,000 documented TB cases, MDR-TB cases. Regarding the mortality of HIV and TB, if you take almost 10% mortalities from India. Overall, the cases in India are around 71,000, and the mortality is 9,500. So with this background statistics in mind, we have to go to the lecture. Next slide. So what is that? The definition. So previously we were telling MDR-TB and XDR-TB. Now we have a official definition for revised definition for with our PMDT guidelines. So what is pre-XDR? That term was used only by experts previously. Now we are using the term pre-XDR officially. So what is that? Here there is MDR-TB or resistant TB, that is plus. If you are resistant to quinolone, it's called a pre-XDR-TB. Same thing, XDR-TB is previously it was called INH, rifampicin, and the second line injectable and quinolone. Now it has been changed. Here, MDR or resistant TB, along with that, resistant to quinolone, and also at least one additional group A drug. So what is the group A drug? The first line, our armamentarium against drug-resistant TB, we have the bedaquiline, linezolid, and the quinolone. So either bedaquiline or linezolid or both, and along with quinolone means it is a XDR-TB. So this is the revised definition. All of us should be knowing that. Next slide. So what are the newer drugs you have for the Pmdt? So what are the newer drugs we have? The bedaquiline and dilamarin. So bedaquiline is already, all of you know that. Previously it was used as a conditional access program. Then now it's being inducted into the regular drug-resistant TB program. So above 5 years up to 18, above 15 kg can be used with the collaboration or consultation of pediatricians. And dilamarin is above 6 years of age. 6 to 11, you can use it as 50 milligram BD, and about 12 years, 100 milligram BD. So what is that important is that bedaquiline is a group A drug, first line drug, whereas dilamarin is only a substitute drug. It is in the group C. So wherever you are going to use bedaquiline, you have to use it up front. Then if it is not supposed to, cannot be used, then you have to use the dilamarin as a substitute. And recent data review from the WHO has shown that whenever there is a unique situation where you have to use both bedaquiline and dilamarin, can be used with no problem in the safety concerns. So next slide. So what is that new things in the, we are now going to see the Pmdt 2019, the guidelines were issued. Then what had happened during the pandemic in 2020? We were not having much of a revision. Now in the March month, we had our NDLS in the March month on management of MDR-TB. After that, the technical resource group, the Central TB division, the NIRT, and all the other apex institutions have come together. And we have now the revised guidelines in the 2021 March. In that, very clear-cut guidelines have been given. So what is that in the pregnancy? So it's a special situation wherein our ARTMOs will be coming across patients with HIV patients in the pregnant patients. So what is that we should know? The uteromic should not be given in the first 32 weeks of pregnancy because of the teratogenic effect, and also in the fetus it can cause hypothyroidism in the second trimester. But what is that they have found out? In the study in South Africa, they found out they used bedaquiline. The birth weight was slightly less. But after 1 year of age, it was developing normally. The child was developing normally. So there is not much of a risk of using bedaquiline in the pregnant mother. But the use of bedaquiline should be in consultation with the obstetrician and physician, and the risk of benefit should be explained to the patient also. Next slide. So this is a management of MDR-TB during pregnancy. For benefit of our junior colleagues, briefly I will tell you the algorithm. Like the duration is very important. This less than
Participants are requested to kindly bear with us. Sir will join in 2 minutes.
Am I audible now? Sorry, there is a technical issue.
Yes, sir. No issues,
Yes.
sir. Yes.
So the pregnancy, if it is 24 weeks, then there are two categories. If it's more than 32 weeks, means we can only use the etinomide and the other things like the eutronomide may be considered after 32 weeks of gestation. But less than 32 weeks means we have to be very careful. We can continue a longer oral bedaquiline containing regimen with the consent of the patient, because the bedaquiline is safe. Only thing is that low birth weight baby is born, and then after 1 week there is a catch-up growth. So we can explain and give a longer oral bedaquiline containing regimen. So less than 32 weeks, eutronomide should not be considered. More than 32 weeks may be considered in a thing, and it has to be very carefully monitored. So this is the newer guidelines being given in the management of MDR-TB patients during the pregnancy. Very, very important. Less than 20 weeks, it could be made 24 weeks. More than 24 weeks. Less than 20 weeks, avoid and advise MTP. Done means you can go ahead with the routine drugs. If it is not done, unwilling for MTP, we have to see whether less than 32 weeks or more than 32 weeks. Less than 32 weeks means better to avoid eutronomide. More than 32 weeks, you can give eutronomide. Less than 32 weeks, we can give all oral bedaquiline containing regimen also. Next slide. So what is that? Now we have come to we have finished. Now the newer drugs, mainly the newer drugs are the bedaquiline and Delamanid. So for the benefit of our junior colleagues in ART centers, what is that we have to keep in mind? The Delamanid, there is not much of a drug interaction with tenofovir or efavirenz, that is NNRTA, NRT, then lopinavir, ritonavir PS. So there is no dose adjustment is required when you use Delamanid, newer drug with the ARV agents. Whereas with bedaquiline, previously we were using with efavirenz. That time we were using along with the efavirenz previously. But what is the newer guideline says? Because of the induction of cytochrome P 453A4, there will be reduced exposure to bedaquiline. That is reduced concentration of bedaquiline. So we have to use a lopinavir, ritonavir, or that also will be having a QTC prolongation, where efavirenz will reduce the concentration of bedaquiline, lopinavir, ritonavir will increase the concentration. So we have to be careful when you are using bedaquiline. So dolutegravir can be safely given with BDQ and Delamanid. Now we are going to the dolutegravir based regimens. So there is no problem with our newer drugs. So we can safely give both bedaquiline and Delamanid, because previously when we were giving efavirenz, we had a problem. Now we have no problem when you are going to give a dolutegravir with the newer drugs. Next slide. So what is it then? Again, what they have given in the guidelines. Previously, when the CNS tuberculosis like TB meningitis or tuberculoma of brain, we had some fixed the guidelines where we have to use the all oral bedaquiline containing regimen. Now we have given some specific instructions like the drugs levo, eutronomide, cyclo, and linezolid can penetrate the CNS well. So that point we have to take into our mind and consideration. And iodocyanates and parasites can be used provided they are susceptible. Then PS and EMB, they don't have a good penetration to CNS, so should not be counted. PAS and ethambutol. And the aminoglycosides only, when the meningitis is there, they only penetrate. Otherwise, they are not useful in a tuberculoma or something. So little data is there on clofazimine bedaquiline. So what is that? Whenever you are going to formulate a longer oral regimen for a CNS TB, you have to take into modify the regimen as per the newer guidelines, like the more better penetration drugs like quinolones, eutronomide, cycloserine should be used, linezolid should be used, and avoid PAS, ethambutol, and only in meningitis you can use the injectables. Like that, we have to be very careful. Next slide. So what is that? The PMDT program. Next slide. So next, Roshan, next slide. Am I audible?
Yes, sir. The previous one or the next one? Please check. I'm sharing the slides, sir.
Yeah, please. Yeah. Next slide you can go, Matt.
The previous one or the next one?
No. Before that, there is one slide before. One slide before. Okay, no. Previous slide, previous. After that, sorry, I think there is some, no. Next slide. Next. come forward. No. It's okay. I think one slide is there, something missing. That is not very important slide. Mainly there is a DRTB center in medical colleges. So there's mandatory. The National Medical Commission has issued a gazette notifying that all the medical colleges by the first batch, when it enters the 4th year, they should have a DRTB center. So now we will come to the DRTB diagnostic algorithm. So what is that here? Now we have made it very simplified. So this is very, very, very important in that how to diagnose in our setup the MDR-TB and how to go about it. So here we have the 3 columns like presumptive TB, all notified non-responders. Here you have the presumptive TB, HIV, our important consideration today, extrapulmonary TB, smear negative, but X-ray is suggestive of TB, vulnerable population like diabetes, urban slum, and elderly people, and immunocompromised people, and contact of DRTB, also contact of DRTB. All these are called presumptive TB as well as drug resistant, presumptive. So all these 3 categories upfront, we are going to do a CB-NAT. So very, very important that we are going to do a CB-NAT. And whenever there is available, we are going to do a culture isolate for a drug, liquid culture isolate for all the drugs. So what is that in the CB-NAT we are going to get? If it is RIF resistance on the left-hand side, RIF resistance detected means it's a case of MDR-TB, rifampicin resistant TB, where you are going to subject for a first-line LPA, second-line LPA, then DST for moxi, linezolid, if it is available, like bedaquiline, all these are, if available, we are going to use it. So it is a RIF resistance detected means first-line LPA, second-line LPA have to be done mandatorily. Then what is going to do if it's a RIF resistance is not detected? Drug susceptible TB means we are going to do a first-line LPA. So first-line LPA, why we are doing a first-line LPA? To find out the INH monoresistance. So INH monoresistance is there. Then we are going to see the second-line LPA result to find out the quinolone. Quinolone, because we are going to use in the INH mono mainstay treatment is we are going to replace INH with quinolone. So quinolone is very, very important. That's why we are doing a second LPA. If quinolone is resistant means then our regimen, INH mono regimen will get jeopardized. So we are going to concentrate on that. Suppose INH resistance is not detected, it's a drug susceptible TB, then we are going to go about doing the routine care. Next slide. So next is that it's an integrated drug resistant algorithm where the previous slide you have seen how to diagnose. Here, same thing, you have incorporated the treatment regimen part also. So same slide. Now what is that we are going to see in this? You come down, second tier, third tier. RIF resistance is detected. The red side on the left hand side means we are going to do a first line LPA, second line LPA, then we are going to do a liquid culture DST if available. The star sign is if it is available, we are going to do. So next, what is going to be happening? So what is that? There are 2 things. You have a DST based criteria. If it's not available, non-DST based criteria. So what is that non-DST based criteria in a resource limited setting? History of more than 1 month, use of second line drugs or any intolerance to the main shorter MDR drugs. In that case, we cannot use a shorter MDR regimen. Otherwise, everything is okay means we can use a shorter MDR regimen. At present, we are using a injection containing, second line injectable containing shorter MDR regimen. Suppose if it is, the results are there, DST is there, where there is a quinolone resistance or any additional resistance like a falling regimen or drug intolerance, then more than 1 month defaulter or lost to follow, then we are going to go for the all oral MDR-TB regimen. So this is on the left hand side. On the right hand side, the green column, you have the RIF resistance not detected. Then you are going to do a concentrate on the first line LPA. So first line LPA will show what? H resistance or not. Already RIF is not resistance. So H resistance means then that's a red column. H resistance detected means you have to do a second line LPA and drug sensitivity. So we have to have an all oral H mono bar poly regimen. We have mainly it's a H mono regimen where 6 to 9 months. We'll be seeing those in the subsequent slides. So that is important thing. If HSS is not detected means we are going to continue the first line treatment. So this is a very important slide where both the diagnostic as well as treatment algorithm is integrated. So this is very, very important. You can leisure time, you can go through this. Any confusion also, you can get back to your senior colleagues. Next slide. So now what is the standard regimens available under the PMDT? We have the H mono bar poly regimen. Then we have the shorter MDR regimen for the MDR refractory TB. And third thing is the longer oral regimen, all oral regimen, which may contain the newer drugs or may not contain the newer drugs. So these are the main 3 regimens. Next slide. So now we'll concentrate on the H mono. H mono means isolated INH resistance. That was a big problem during the earlier days. This INH mono we were not able to find out, and frequently the patients relapsed to us. Now we know up front we are doing gene expert followed by first line LPA. We can easily find out the INH mono. Sometimes there will be a polydrug resistance like INH along with some quinone resistance or some other thing. We have to be very careful. Not quinone, any other TB, first line TB drugs like a EMBSM, that's a polydrug. So what is the regimen here? 6 to 9 months. Remember, minimum 6 months and maximum 9 months. So here INH is replaced by levofloxacin. Simple. INH is not working, we are giving levofloxacin. So the regimen is levofloxacin, rifampicin, EMB, pyrazinamide. No IP, no CP. It is a full duration of 6 months. So where it could be extended to extra 3 months, patients with extensive disease, bilateral cavitary, extensive disease, uncontrolled diabetes, comorbidity, maybe even the HIV, you can add extra pulmonary TB, INH resistance, but extra pulmonary, like a cervical lymph node, bone TB, all this extra pulmonary. At the smear is even positive at end of 4 months, you can extend by another 3 months. And where regimen is modified, suppose you are not able to use a levofloxacin, or you're going to substitute, or suppose you are not going to use a EMB, you are going to substitute something like that, you are going to use it for up to 12 months in CNS, skeletal, and miliary. Miliary is a disseminated form, hematogenous spread. So you are going to use even up to 1 year. So this is the H mono regimen where 6 months, sometimes it's 9 months, even up to 12 months in miliary and bone TB and CNS TB. Only thing here, it could be no other new drugs are not used in the H mono or poly regimen. New drugs are not recommended. Next slide. So now we have found out the H mono. This is mainly for the benefit of colleagues who are working in the Drtv center or linked with our ART-DF. So how to replace a sequence in H mono? So nothing, it's just a crowded. So just I'll tell you what it is. If you cannot use levo in the already told last slide, 6 to 9 months. If you cannot use levo, you use linezolid. That's all. Suppose you cannot use linezolid, you have to have 2 drugs from group B. You know, group A is the top 3 drugs. You have the bedaquiline, moxifloxacin or levofloxacin, plus linezolid. These 3 are the top 3 drugs, group A. Group 2, you have clofazimine and cyclone, 2 Cs. So what they tell, first group, you are not able to use the linezolid or the first line drug, then you can replace with 2 drugs from group B. That's all, simple. Suppose you develop resistance means you have to shift to the longer or all oral regimen. So that was a case scenario where after 4 months maybe resistance develops, then they will go back, they will go to the conventional regimens of MDR. If 2 drugs could not be used in the 4 drugs, already told you H mono means we are going to use levo, rifampicin, pyrazinamide, EMB. Then they have to use additional 2 drugs of the 3 like linezolid. So this is mainly for the benefit of the MDR-TB or Drtv center junior colleagues. Next slide. Yeah, this slide is also a crowded slide. treatment algorithm of MDR-TB regimen. So you just concentrate. I'll just tell you. Rifampicin resistance deducted means upfront. So it is a case of drug-resistant TB. Then we will do a first-line LPA and second-line LPA. If there is facility, you are going to do a liquid culture-based DST, drug sensitivity testing for bedaquiline, clofazimine, whatever the drugs, Dilaman, all these you are going to do, pyrazinamide, everything. So what is that? Treatment evaluation. You have to check on the NICSHI or the DST lab for if the results are available, first line and second line. So up front, you are going to give them a shorter MDR regimen only because it is more, the cure rate is very good, the field conditions, and the treatment is only 9 to 11 months. So we are to provide them with the shorter MDR regimen if they are eligible. That is the thing. Suppose if they are not eligible because of the pre-XDR or XDR due to the second line results, or you cannot use any of the shorter MDR regimen like the 7 drugs. If you cannot use one drug also, you have to go for the conventional all oral longer regimen, 18 to 20 months regimen. This is the important thing which comes in here. There is one important point I have to tell you. Then the left hand side, you see the left hand side, the circle is there, the second circle, bigger circle. What is that? No additional resistance detected, or it's resistance detected with CAG or INH mutation or both. What does that means? See, shorter MDR regimen, you are going to do a first line LPA, second line LPA. Second line LPA, anything is there, quinolone resistance or any other group A drug resistance, you are going to go for the all oral. Suppose they are sensitive. So you have the CAG and INH mutation represented. So INH-A mutation is present means you can use etianamide. So please note it down. INH, they will be giving the result along with this rider. See, H resistance noted, and subsequently down it will be CAG mutation noted means etianamide cannot be given. So you have to abandon the shorter MDR. Suppose high-dose INH CAG mutation, you can use high-dose INH, etianamide can be given. Sorry, I just made a mistake. If INH-A mutation is there, you cannot use etianamide. So we cannot give shorter MDR regimen. That's the important point you should know. INH mutation A is there, INH-A mutation there. We cannot give etianamide, so we have to go for the all oral. Suppose only CAG mutation is there, you can use high-dose INH as well as etianamide. So that's the important point you should know in this slide. We'll go to the next slide. So what is that now we are using? The 9 to 11 months injection containing regimen only we are using. What is that? Intensive phase of 4 months. It can be extended up to 6 months. Continuation phase 5 months. So first 7 drugs followed by 4 drugs. So what is the important point you should know? The 4 months, after 4 months, you are going to extend to 6 months. The injectable has to be made weekly thrice. What is that injectant we are using? Kanamycin and amikacin. But the problem is that we are going to slowly phase out the injectable second line because of 30% toxicity, ototoxicity, cochlear, vestibular toxicity. So this is the injection containing regimen being used all over. But what is that Pmdt 2021 guidelines is telling? We are going to use a all oral bedaquiline containing shorter regimen. That I will come to in the subsequent slides. So what is the important point you should know here? If any drug needs replacement because of any adverse drug reaction, any other thing, we have to switch to all oral longer regimen. Here it is like all the 7 drugs should be used. If one drug cannot be used, then there is no point. We have to go for the 18 to 20 months all oral regimen. So important things which you know in the shorter MDR regimen is that here any extra, that is the DST criteria, non-DST. So non-DST, more than 1 month of second line drugs being used, any pregnant women, any adverse drug reaction to any of the 7 drugs, we cannot use the shorter MDR regimen. Whereas DST based, you have the second line injectable resistance or quinolone resistance, pre-XDR, XDR, you cannot use a shorter MDR regimen. Same thing, there is INH resistance, but in the subsequently, if there is CAG mutation is there, you can use the shorter MDR. But INH-A mutation is there, Utinamide cannot be used, so you cannot use a shorter MDR. So this is the main carry-home point of the shorter MDR regimen. Next slide. So what is that now? The purpose of our session today is that in 2020, WHO has recommended a shorter oral BDQ containing regimen. So we are going to avoid the aminoglycoside, second line injectable, so that lot of adverse drug reactions is prevented, and we are having an all oral regimen, shorter regimen. So what is that? This is very, very important. In here, what are the exclusion criteria is that more than 1 month they are exposed, we cannot use it. Also, quinolone resistance to be excluded. Suppose quinolone is resistant, means this cannot be used. So what is that here? This is a very important thing. Now it's been piloted in 7 states, and slowly it will be upscaled to the entire Pmdt ART program. So what is that here we are having? In the IP, we will have 6 months of bedaquiline. Remember, 6 months, but only 4 to 6 months of the other drugs. Same thing. Like short MDR, it is replaced by, the injectable is replaced by bedaquiline. Here you have levomoxy, clofazimine, pyrazidamide, EMB, iodocyanate, same 7 drugs only, but the injectable is replaced with bedaquiline. Bedaquiline has to be compulsorily given for 6 months. The additional drugs can be 4 to 6 months in the IP. CP is 5 months. What is that? Bedaquiline is there 6 months. After 6 months, it will be stopped, and you will be remaining levomoxy, clofazimine, and pyrazidamide EMB. So remaining 4 drugs. So total duration is 11 months. 11 months treatment. This is the important guidelines which has been going to be implemented in our program. Next slide. So now the new WHO recommendation, shorter oral BDQ evidence. Why this has been fast-tracked? They have done a programmatic data based on mainly from South Africa. The injectable agent was replaced by bedaquiline among 891 patients. That was a very big number. So next slide. So what is that? Here there was a good response, 73% treatment success compared to 60 with the injectable short MDR. Next slide. So shorter MDR, 1 minute. A shorter MDR regimen, we are going to use 9 to 11 months. So now it is being piloted in 7 states. Shorter regimen is to be launched in India in 7 states to be scaled up across the country. So all our ART colleagues should be aware of this. We are now going to develop a bedaquiline containing all oral shorter MDR regimen, 9 to 11 months. Here it will be second line injectable resistance, also not a problem here. We are not going to use the injection, so we can as well use the short MDR bedaquiline containing regimen. So initial phase 6 months of BDQ, 4 to 6 months of the other 6 drugs, levo, all the other drugs. Then continuation phase 5 months will have the levo, pyrazidamide, EMB, and clofazimine. So the iodocyanate, etulamide, and the bedaquiline will go. So this is the important thing you should know. Next slide. So the various shorter MDR criteria. What is the criteria? Next slide. DST based. Okay. So criteria 1 already we all this we know. RIF resistance should be there. H resistance based on A mutation only, or based on CAG mutation only, or not both. So we already discussed. INH-A mutation is there. Utinamide cannot be used. So short MDR cannot be used. CAG mutation is there. We can use. So then MDR resistant TB with quinolone resistance should not be detected. If it is detected, means we cannot use a short MDR regimen. So these are the inclusion criteria. Next slide. Other inclusion criteria, 1 month already we know that. If they are exposed to more than 1 month, documented is there. Better to go about by not. But there is a one rider is here. Suppose you have a documented susceptibility is there. If this medicine, their sensitivity is there, then you can use it. Then you can forget about the 1 month usage. The documented drug sensitivity from accredited lab is there. You can use a bedaquiline containing short MDR. Next slide. So other things, no extensive TB. So what are the inclusion criteria? The patient should not have an extensive disease. They should have only a moderate disease. The presence of bilateral cavity, extensive parenchymal damage on chest radiography should not be given the short MDR. Children aged 15 years under with cavities, bilateral disease should not be used. So no severe extrapulmonary disease like biliary TB, meningitis, CNS TB, where there is disseminated extrapulmonary TB should not use. We have to go for the all oral 20 regimen. And here one important point you should know. Previously in HIV patients without with extrapulmonary we were not giving short MDR. Now we can give only thing without severe extrapulmonary. We can be given short MDR. So PLH without severe extrapulmonary like a cervical lymph node, we can give shorter MDR. Milder forms of extrapulmonary disease, you can give shorter MDR, all oral, or even now with the injectable regimen. This is the newer guidelines. Next slide. So it's further continued. So what is that inclusion criteria? Age 5 years to less than 18 years, weighing above 15 kg, you can give along with the consultation of pediatrician, bedaquiline containing regimen. So women more than 32 weeks, you can give with consultation, obstetrician, and lactating, you have to stop the breastfeeding, replace it, then give. So these are the other inclusion criteria being followed in the bedaquiline containing all oral regimen. So like the DSD based, already I told you, injectable resistance is not a problem. Presence of secondary injectable resistance is not a problem. We can as well give a short MDR BDQ containing regimen. There is a quinolone resistance. We have to exclude the short MDR regimen. We have to go for the all oral. Then the second exclusion criteria, already I told you, patients with H resistance detected with both CAG and INH, we cannot give. We cannot give. That is the important point we should know. Next slide. Next slide is that. Next slide. So principles. I think we'll go to the next slide. Yeah. Replace principles of replacement sequence. 1 minute. Yeah. Here, this is mainly for the benefit of the Drtv coordinators and the medical officers. Here, no, how to replace the as per the this was the oldest 2019. We can ignore it. We'll go to the next slide, please. So 1 minute. Can you go to the next layer? 1 minute. As per the Pmdt guidelines. No, go to the next slide. Next slide. Yes, correct. So here, the principles of replacement mainly for the benefit of the Drtv program persons. But anyhow, we'll take up the points. The use of the drugs for their efficacy, no demonstrable resistance, prior use, side effects profile, and background resistance to the replacement drug in the country as per the National Drug Resistance Survey report. So we cannot, just like that, we cannot use our personal experience and replace the drugs. We have to go about by the efficacy, their rating, grading, and other things. Regimen should preferably be fully oral. However, in certain conditions, we can use the injectable things. And minimum thing is at least 4 to 5 drugs to be used in the initial 6 to 8 months, and following that 3 to 4 drugs in the last 12 months. This is the basic principles of replacement drugs. Next slide. So what is that replacement sequence? You just remember the group C, we have, see that group A and B are the 5 drugs. Group A, you have the top 3 drugs, bedaquiline, moxi, and linezolid. Group C, you have the clofazimine, cycloserine, sorry, group B. So these top 5 drugs are to be used. Only then you want to replace it. We have the group C. Group C, what is the order? Dilamanid, amikacin, pyrazinamide, etonomide, PAS, ethambutol, and lastly, imipenem, celastin, imipenem or meropenem, amoxicillin. So if they are really sensitive. So combined use, you can use bedaquiline dilamide in the regimen if recommended, if appropriate design. And dilamanid and amikacin will not be started in the final 12 months. These are the gross guidelines they are given. No replacement of any drug is in the final. Suppose you are using in the continuation phase 4 drugs. 1 drug is becoming a adverse drug reaction. No need to replace. You can use the other 3 drugs till the end of the treatment. That is the implication of that slide. So use of bedaquiline dilamide beyond 24 weeks there is some special consideration which will be, you have to get the opinion of the nodal or the experts, and then you can use it. So this is very important that we cannot use, as such, we cannot proceed beyond 24 weeks of special newer drugs. Next slide. So what is that further? Imipenem and Celastin is the IV. So you have to have a admission. You have to have a peripherally inserted central catheter. So these are all very, very bothersome. So this is for the benefit of the DRTV. Next slide. Next slide. So here nothing. You just imagine, remember this. Group A drug you are going to not use. Then you have to go for the none drugs to be replaced. None means 3 + 2, top 5 drugs. Suppose group A one you cannot use it. You have to use one from group C. Suppose one group B means you have to use one from group C, like that. Suppose one group A and one group 2 + 1, 3 drugs you cannot, or 2 drugs from A and B you cannot use. You have to use 2 drugs from group C. So this is for mainly for the benefit of the DRTB. So they have a formula. Just they have to apply it and replace the drugs. Simple. When group A is being stopped, you have to use one group C. Group B is stopped, one group C. Suppose one group and one group B is being stopped, means you have to use 2 groups. Next slide. So same thing. So this is a bit confusing, not to be, with whoever is going to use it in the program, you can use it as a desk. They can keep it in their tabletop and use this formula. Next slide. So these are the same thing. Replacement sequence is dilamanid, amikacin. In the order you have to replace. You cannot change the order. The replacement drugs, the group C they are given according to the experience, their efficacy, and their expertise. They are given the replacement sequence. Next slide. Same thing, the yellow. So what is that? Next slide. Yeah. Next slide. Difficult to treat TB clinics are being now formulated in Bihar, Tamil Nadu, Maharashtra, and they are going about with the virtual platform and guiding youngsters. So this is very important. National experts mentor the difficult to treat TB clinic are being in Tambaram also is being conducted. Next slide. In pediatric population, what is that? Children more than 5 years, more than 15 kg, you can go with the all oral regimen. More than 5 years. Like adults only, you have to do it along with the consultation of pediatrician. Maybe the duration of treatment can be less if they are the pediatrician want the drugs to be stopped after, say, maybe 1 year, 6 months, something like that. So less than 5 years means neither the bedaquiline nor the dilamanid can be given. You have to modify the regimen along with the expertise of the pediatrician, and you have to preferably avoid the injectables because of the hearing loss and nephrotoxicity. So what is that? Next slide. Yeah, the next TB. What is the next TB? 1 minute. What is that? Next TB? Testing new potential treatment for XDR-TB. This is mainly for our benefit of the postgraduates. So what is that? Testing a novel oral regimen for XDR-TB or failed MDR-TB, intolerant, like a salvage regimen. They have tried BPAL, bedaquiline, pretomanid, linezolid for 6 to 9 months, supported by the Global TB Alliance group. It could shorten, simplify, and improve the XDR-TB. So this is called mixed trial. If successful, it can be extended to all the programs. Next slide. This has come in the New England Journal of Medicine, March 2020. They have analyzed and successful outcome in 90% BPAL. So it's a great landmark trial which will revolutionize the treatment of drug-resistant pulmonary tuberculosis. Next slide. So this is what the WHO's consolidated guidelines. So the treatment 6 to 9 months BPAL, bedaquiline, pretomanid, and linezolid under operational research conditions. It is not in routine program. So it's a conditional access regimen. It can be used in whoever is in a salvage or palliative where all the drugs are failed or something like that, and who are not exposed to bedaquiline or linezolid and who are being exposed to not more than 2 weeks can be given this ultra short BPAL regimen. Next slide. BPAL is an exceptional case in a design regimen. Already I told you. So NTP will ensure availability of these drugs under special conditional access program, BPAL regimen, benefit for our postgraduate colleagues. Next slide. So interim treatment outcomes. So this is only for the program people. What is bacteriological conversion means? What is the time taken to become negative? Bacteriological reversion means already sensitive becoming resistant. These are all the technical terms. Time to conversion is from last positive, how they became culture negative. These are all mainly for our operational research and other things. Next slide. What is treatment failed? Whoever needs other treatment, like because of drug reaction, was switched to other treatments called treatment failed. Cured means totally cured. You know all this. Treatment completed. Everything is a patient who completes the treatment as per the policy, NTEP, but outcome does not meet the definition for cure, will be treated as treatment completed. Next slide. So died, everything is for the program, how to follow up. Okay, next slide. So now we come to important point. How to manage the household contact. Previously, we were not having any guidelines. We were in the gray, we are in the dark. Now we have household contacts of MDR-TB with the quinolone sensitive means we can give 6 months of levofloxacin. Like what we give in our ART clinic, INH prophylaxis, 6 months. Same thing here, levofloxacin, 6 months, because these patients are MDR-TB quinolone sensitive. Suppose H-resistant cases means you can give 4 months of rifampicin. Household contacts of resistant TB with the INH and quinolone susceptible means 6 months of INH. Already what you are giving in the ART, we can give here for the household contacts of resistant TB with the H sensitive means. That's a very rare situation. Then to be introduced in a phased manner for all. Okay. And the household contacts need to be monitored 2 years for any symptom development. Important thing. Any MDR-TB contact, household contact, 2 months, 2 years, you have to follow them up. Next slide. So these are the various doses how to give for the various weight bands. This is the same thing I told you. So this is the thing. Next slide. So conclusion here, introduction of newer drugs, increased chance of recovery, treatment success. So you have to, at the earliest, use the newer drugs, bedaquiline and dilamanid. So whenever possible, injection-free regimen should be preferred. Carefully see the exclusion criteria before formulating the shorter MDR or either injectable or oral regimen. Replacement of drugs should be under strict guidelines. How to replace the drugs that will ensure more success. And bedaquiline not given together, concerns have not been reported, so you can boldly give both the drugs together in special situations. Household contact should be offered prophylaxis as per the guidelines and 2 years strict follow-up. Next slide. So 2 slides on the ARV regimens for HIV, newer TB. These are the operational guidelines issued by NACO. Dolutegravir can be used safely in newer TB drugs, bedaquiline, dilamanid. All TB HIV, co-infected HIV with drug-resistant TB should be referred to the linked Drtv center for starting the treatment for drug-resistant TB. PLHIV already on dolutegravir regimen may be continued with the bedaquiline Drtv regimen. No need to substitute any drug. Dolutegravir is very safely can be given. Whereas PLHIV on NNRT bar PA-based regimen, substitution of PA is needed if they are being used with bedaquiline or dilamanid because of QTC prolongation. So PA-based regimen, you have to be very careful when you are going to use with bedaquiline or dilamanid. Next slide. So TB-HIV patient requiring a PA-based regimen, second line, third line ART, you need a coordination between SASAP and the DRTB center for considering a non-BDQ regimen. So in case an effective regimen cannot be made out, then you can use the bedaquiline with the PA-based regimen, but with intensive monitoring like daily ECG or weekly ECG for drug toxicity. HIV on AR treatment with boosted PA, if treated with bedaquiline, can be monitored closely. So these are the guidelines, our operational DO letter issued to us. And next slide. And thank you. And now we have the case study. We have now discussed that management of our MDR-TB. Now over to Roshan to take up the case study, and we'll have a discussion because the time is running short. We have another 10 minutes time. I think, Roshan, I'm sorry I gave you less number of minutes. Over to Roshan.
Thank you, sir. I would also like to thank Kumar sir and LDLS for this opportunity. Thank you, sir, Kumar sir, for overwhelming of the MDR-TB management. So, moving to case study, this is an 44-year-old male, a lorry driver by occupation. He presented with us with cough, fever, loss of weight for more than 10 days, and he was married with had a history of smoking. There was no significant past and family history. Second slide, please. On examination, he was malnourished. He had a diminished bed sound over the right infrascapular region. Other systemic examination was unremarkable. Next slide, please. On investigation, sorry, couldn't put up the X-ray. X-ray was not available at time. WBC was 5,500. Hemoglobin was 10.6. Random blood sugar was 110. Urea creatinine left were within normal limits. Next. So, on routine examination, HIV was turned out to be positive. Sputum AB was positive. Gene expert showed MTB detected, refer assistant detected. XHSPA view, which showed right lozenge and heterogeneous opacity with right CP angle planted. Ultrasound thorax and abdomen was done. Thorax showed right minimal pleural vision. Ultrasound abdomen was normal. So we did a pleural fluid aspiration. Pleural fluid aspiration showed an sugar of 60, protein was around 45, LDH was high, with differential count of about neutrophilic predominance. It was a most of an exudative neutrophilic predominance. Next slide. Okay. So CD4 count was done. It was 218. The patient, this is basically a case of a primary MDR, more of a disseminated TB having a parenchymal and pleural involvement, and it's a newly diagnosed immunodeficiency. Okay, patient was started on a shorter base. Next slide.
Roshan.
Yes, sir.
Sorry, you can tell because you are a pulmonologist, you can tell the pleural fluid. What is that? What is the LDH like? And for the benefit of junior colleagues, what is the cell count like? How you have come to the conclusion?
Sure, sir. Sure, sir. So this patient was diagnosed as an exudative effusion based on the protein value, LDH value, and differential count was more than 75. Okay, if it's anything more than 60, we call it as a lymphocytic effusion. This patient had around 79. It was more of a lymphocytic effusion. Lymphocytic effusion most commonly seen in tuberculosis. Second most common is malignancy. Where exudative lymphocytic effusion, one of the first differential diagnosis that we come across is in tuberculosis. Okay, and in the setting of sputum positive, so our diagnosis are made even more easier with this finding. And the CD4 count was around 218. We know that around less than anything around 200, less than 200. Opposite infection like TB is most common in a patient with HIV. Yes, sir.
Yeah.
And this patient was, as we know, as sir already said, that this patient is in pale HIV with non-severe extrapulmonary TB or written, which is not an extensive lung involvement. Okay. So this patient was eligible for a shorter regimen. We started on moxifloxacin, pyrazinamide, ethambutol, clofazimine, kanamycin, and ethonomide. After tolerating the regimen, the patient was then started on TLD regimen, which is the latest, what you call as with altogether. Next slide. Yeah. So after 2 weeks of ADT, patient started tolerating. Then we put it on TLD regimen. This patient's LPA report, first line LPA and second line report LPA are awaited. Yes, sir. So primarily, the primary MDR-TB, usually the prevalence is about 5% to 28%, varies from global, whatever the global data we have, it suggests about 5% to 28% of primary MDR-TB. So whenever an HIV patient with low CD4 count, always have a suspicious of to rule out MDR-TB. So usually recommended is gene expert because the patient had a new presentation, we did a sputum AB and gene expert, but recommendation is always how to do an gene expert. If gene expert is positive, then do an first line LPA, as sir already mentioned in his presentation elaborately. Once gene expert is positive and rifampicin is resistant, then proceed with the first line LPA and second line LPA. And if patient is eligible for a shorter MDR regimen, whatever the criteria are laid out, The patient should be a rifampicin resistant, should not be a resistant to fluoroquinolones, and there should not be an extensive disease, either pleura or parenchymal. There should not be any extensive disease and pregnancy lactating woman. So this patient was shorter MDR regimen and TLD regimen after 14 days. Once his LPA report comes, we will definitely review this case and see how it is, resistant pattern.
Thank you, Dr. Roshan. And that's a very good case because, as you rightly told, only 3 to 5% in our setting we have seen primary MDR. So this patient could have been infected with a primary MDR. So we have rightly upfront, you have done a CBNAT so that you could diagnose the primary MDR very early. Previously, usually 2-3 years back, we were repeating the CBNAT. Whenever we got a primary MDR, we used to repeat. Now in the program, because of the good sensitivity and thing, we are not repeating. As you have rightly done, we have straight away proceeded to shorter MDR. So here the patient's CD4 is less than 250, we are told. That's why there is a lower lung field TB and also parenchymal with pleural effusion. So it's like a atypical presentation. And rightly, you have diagnosed very early because usually in HIV and TB, the diagnosis gets delayed. But here with the use of the CBNAT, you have diagnosed very early and you have started them on the shorter MDR. So in the program now, we have the bedaquiline upfront. It can be used in a shorter all oral regimen where if it comes to extended to all the upscale to all the states, we can use that also. Only thing in HIV, if there is some very disseminated, extensive extrapulmonary or extrapulmonary disease, then we have to go for the all oral. Otherwise, we have to first present the patient with the shorter regimen so that more the patient's compliance will be better. So thank you for sharing a nice case. And I think any observations, I think first of all, I want to thank Dr. Rupak Singla and Dr. Neeta Singla for allowing me to present their slides. I asked them for the permission and they've given me the permission. So thank the NIRTD team for giving me the permission to share the slides. And next, any observations, senior colleagues are there, senior people are there, any observations and experiences they can share. We have some 3-4 minutes time before it's 3 o'clock, please. So there are some queries have come. What made us say that it's a primary MDR, not an acquired case? Oh, very good question. Only thing is that, see, the history is important. If any history of previous treatment, anti-TB drugs is there, then it becomes acquired. So here there is no history of any anti-TB treatment. Previously, they have made out during the stay in the hospital. Then what had happened? They have given the sputum and the gene expert. So if there is no previous ATT, no exposure to TB drugs or no exposure, no previous TB infection, then it is called no exposure to the TB drugs de novo. So it is a primary MDR. Usually it is maybe, I don't know, maybe when we are working 2 to 3%, there is a primary. Acquired was like in a retreatment case, already exposed to the TB bacilli retreatment, it was 11 to 12%. And in the new patients was 2 to 3. So that is why it's called a primary MDR, not an acquired MDR. So for TB patients, dolutegravir TB is also added with TLDS. Yeah, for in the program, we are going to add a TLD morning, dolutegravir, extra dose till the ATT is completed, we are going to use it. So moxiflox was used in this case. Any reason for not choosing levo? Roshan?
Availability, sir. Availability of that time was moxifloxacin because of that.
Very good. So moxi was used. So it's a levo and moxi, it's not only thing. Only when it's in the drug sensitivity pattern, it comes as levo resistant and moxi high dose sensitive, then we have to go for the moxi. Otherwise, it's not in the program, whatever is available can be given. And I thank my teacher or our mentor, Professor Rashan sir, for attending this. And thank you so much, sir. And the shorter MDR regimen is a package, isn't it? Yeah. So the 7 drugs are to be given as a package. So any problem, one drug cannot be used. Then we have to discontinue and we have to go to the all oral regimen. So we cannot substitute any drug with any other drug. So any other queries there? Yes, I think, okay. If any other sir want anything to be, Dr. Narendran, you want to add anything here?
Thank you, sir, for this
Sir, just a comment that The nice presentation and compilation, sir. So all my teachers are already here. So just that, on the contrary, if you have a sensitive TB patient developing effusion during the course of time, also we have to think of iris. But here very clearly it has been demonstrated when we were doing in iris, there was no expert available to us. Now that we have expert, it's easy for us to see. But even then, expert may be sometimes problematic because in effusion. So look at the CD4s and viral loads. So you can give you can easily find out that kind of just a differential diagnosis. Sir. That's all.
Oh, very good. So thank you, Narendra. You have to keep our colleagues have to keep it in mind the iris when there is a conversion. Okay. If there are no further queries, I think hand over to Dr. Shweta.
Yeah, thank you, sir, for this informative session. Participants can unmute their mics if they have any questions. We can still wait for 5 minutes. Continue this. Please unmute your mic and ask your questions. So there's one question. Any guidance on overall DST profile of LFX versus MFX?
Pardon?
Any guidance on overall DST profile of LFX versus MFX? Amit sir?
Levofloxacin versus moxifloxacin, sir.
Oh, Levo versus Moxi.
Yeah.
Okay.
So, I think
Narendra, you want to take? Narendra?
I think patient who is on levofloxacin resistant can still be considered for high dose of moxifloxacin, sir.
Yeah.
What's the take on?
That is the high dose Moxi. 0.5 sensitive, we can use the usual dose of Moxi. If it comes under 1 at the one sensitive at 1 means you have to use high dose of Moxiflox.
Sure.
And only the programmatic situation, only the Levo or Moxi, not much of a difference. Only thing Levo resistant, we can use Moxi if it is sensitive at and the DST.
So we are getting this question again and again. Should we give an extra dose of DTG 50 mg when treating PLHIV with MDR-TB?
That I think should be in reformation-based regimen, no, sir. I think we should. No, they're asking that altogether 50 mg extra should be added in MDR regime, but that is more for an reformation-based regimen where we given altogether 50 mg BD.
Yes, excellent. So because of the bioavailability is lost, altogether is given. Okay. I think drug-resistant TB it will not come. Yes. Your point is well taken. I think that's correct. You are right.
Yeah. Why cannot we use newer drugs with H mono?
I think the program guidelines, they have all the technical resource group have added that they have contemplated, and they have think that the newer drugs cannot be because the INH is not working. They are adding a potent drug in the Quinolo, and they are giving the intensive and continuation phase. Maybe that's why they have reserved all these drugs for the rifampicin resistant and XDR-TB, the newer drugs. With this, the substituted quinolone regimen, it is good. The regimen is working, so that's why they have not included the newer drugs for the INH mono resistance or poly resistance.
Yeah, no more questions, sir. Thank you once again. Thank you, Dr. Roshan too.
Thank you, madam.
Thank you all.
Yeah, thank you, sir. Thank you to participants for patient listening.